roughly there's about 230,000 Americans every year who are diagnosed with lung cancer. And only half of those folks who are diagnosed with lung cancer were eligible to get screened in the first place. And so there's an issue of the fact that people who are eligible to get screened are not getting screened. And then there's also a separate issue of many hundreds of thousands of Americans every year are getting lung cancer and they're not eligible to get screened because the screening criteria are too restrictive.
Hello and welcome to the Oncology Insights Podcast, brought to you by Wisenetics. I'm Abby Benyo and dedicated to bringing you the latest insights and discussions in oncology. Get ready to expand your knowledge and stay ahead with today's episode. I'm Abby Benyo. I'm an interventional pulmonologist at the University of Minnesota, and I am guiding you along a journey of what is new in the oncology space. Today's guest is Dr. Jeff Yang, a thoracic surgeon at Mass General Hospital, and an associate professor of surgery at the Harvard Medical School. He's also the founding director of the Center for Artificial Intelligence and Innovation Research. He practices all aspects of thoracic surgery, including procedures for conditions of the lung and mediastinum, and specializes in minimally invasive techniques. Dr. Yang has received numerous awards, including recognition for exceptional accomplishment in both clinical care and teaching. In 2021, he received the Harvard Medical School Charles McCabe Faculty Prize for Excellence in Teaching, and Dr. Yang is a member of the American Association for Thoracic Surgery and the Society of Thoracic Surgeons. Dr. Yang describes himself as a thoracic surgeon, principal investigator, advocate, and mentor. I love that. Welcome, Dr. Yang.
Thank you so much for having me.
I'm so excited to talk with you. Would you mind telling me a little bit about your professional journey? How did you get to where you are now as a surgeon, investigator, advocate, and mentor?
Absolutely. So I started being interested in medicine way back because my grandfather had small cell lung cancer and I was part of his care team. I was very close to my grandfather, and we had talked about many different goals. And one of the things I wish he could be around for is to at least see me get into medical school, because I know that was something we talked about a lot. And through his journey, I was introduced into the world of medicine and oncology. And also, I didn't realize this at the time, but early detection, because now that I'm a thoracic surgeon, I realized that if we had better ways of screening at that time, that we probably would have been able to find his cancer much earlier. And he probably could have actually seen me at least get into medical school and be off to that medical school and medicine surgery journey. Then in medical school, had some fantastic mentors in surgery. And so that's how I went on the surgical path to trying to help patients with lung cancer.
Wisenetics turns podcast airtime into brand authority. We don't sell ads, we elevate voices. Curious how far your voice can go to become a reference in the industry and attract more leads? Scan the QR code and discover how we can turn your expertise into unmatched brand authority. Let's transform expertise into influence, starting now.
Yeah, thank you for sharing. I'm sorry your grandfather didn't survive to see you. I often tell my patients, I also treat patients with lung cancer, that, forget whatever you know about lung cancer. This is not your grandfather's lung cancer, right? Like, things have changed so much that I really try to upfront let them know that even if they might have an experience that is really didn't go the way that they hoped it would go with lung cancer, that doesn't necessarily mean that's how things are going to go for them. So it sounds like it's really, really personal for you too. And to all of those who celebrate, happy Lung Cancer Awareness Month. We have lots of work to do. It's a busy month for me and for you. A little bit later, we can talk about how you're commemorating Lung Cancer Awareness Month. So you mentioned early detection. Let's talk a little bit about early detection and lung cancer screening in the United States. Where are we now? How are we doing?
That's a great question. We're overall doing better than we were 10 years ago. So early detection for lung cancer right now, or lung cancer screening, that currently is through the form of a low-dose CT scan. So this is a painless, very quick and easy scan. You can just walk onto the scanner, keep even your shoes on, and get a 2-minute scan, and where the machine takes pictures of your lungs. And it's very safe. It's covered by Medicare. It's covered by private insurance, and it's recommended by all major medical and surgical and oncology associations. The main issue, though, is that most people who are eligible to get screened are not getting screened. So every year there's about 13 million Americans who are eligible to get screened, and there's only about 18% who are getting screened. And so we as a field need to do much better to get people screened. And then the other component of the situation is that roughly there's about 230,000 Americans every year who are diagnosed with lung cancer. And only half of those folks who are diagnosed with lung cancer were eligible to get screened in the first place. And so there's an issue of the fact that people who are eligible to get screened are not getting screened. And then there's also a separate issue of many hundreds of thousands of Americans every year are getting lung cancer, and they're not eligible to get screened because the screening criteria are too restrictive.
And why is that? Why are you seeing in your practice? What can you tell us about why that uptake is so low?
That's a great question. So right now, I think that it has nothing to do with, or it has less to do with the patients and more to do with our health systems. So I think people have studied the different barriers to lung cancer screening, and in general, I think folks have felt maybe people who are eligible to get screened are too busy to get screened. They don't want to take time off from work. They don't care about their health. They are worried about their diagnosis, and so they don't want to know. But what we have shown, and this was published in JAMA earlier this year, is that it's probably not related to that. It's probably related to a systems-wide issue. So, for example, in one study that we looked at, we found that of people who are eligible to get screened for both breast cancer and lung cancer. So these are people who are dually eligible to get screened, so to speak. 65% of them got their mammograms, but only 17% got lung cancer screening. And then we also looked at people who were eligible to get screened for colon cancer and lung cancer. So, and in that population, only 17% got screened for lung cancer, but 65% of them got a colonoscopy and got colon cancer screening. So clearly, if you are able to get a colonoscopy, which is way more involved, bowel prep, you have to go in the hospital, it's a procedure, then you probably care about your health. You probably were able to figure out how to take time off from work to get screened. And so we reported this in JAMA earlier this year, and suggesting that this question of are patients who are eligible to get lung cancer screening, are they hard to reach or are they hardly reached? We showed that they're probably hardly reached, and that puts the responsibility on us in the field, the doctors, the healthcare providers, the policy makers. That the responsibility is on us to try to get the lung cancer screening uptake much higher.
Yeah, I want to amplify something that you said and that I, tell people too, right? You mentioned a colonoscopy is so much more challenging. You have bowel prep, you have to take time off of work, you have to get sedation, you have to get a driver, mammography. I mean, lung cancer screening is the most easy, comfortable, fastest thing. You don't have to be probed, you don't have to be squished, you don't have to be poked, right? So it really is the most easy and most comfortable screening test available, essentially. You don't have to touch anything that you don't want to touch. touch, so it really is not about the screening test for sure. So you're saying it's a system issue, which I definitely agree with that. What can we do in the healthcare system to improve uptake of lung cancer screening?
By the way, I loved how you described that, and it's absolutely true. It is probably the most comfortable screening test. I never thought about that way, but it's so quick and easy. It's just 2 minutes. But with regard to the health systems question, there are several different things that people are working on. So one area is that right now the screening criteria is very complex. So you have to be between the ages of 50 and 80. You have to have greater than 20 pack year smoking history. So that means you have to have smoked 1 pack of cigarettes a day for greater than 20 years. And then you have to either be currently smoking or stop smoking in the past 15 years. That's a mouthful, and it's hard. I remember when I first started in working on lung cancer screening outreach, I had to practice many times to memorize that. It is not easy, and I think that's a huge burden on primary care doctors or primary care providers to have to remember that in the setting of everything else they have to do for the patient in the 15-minute visit. So in that regard, I think that the screening eligibility criteria need to be improved. It needs to reflect what is going on right now. And one big issue is that the reason why the screening criteria were set like this was because there was a large-scale randomized trial. It's a very well-done study and very famous study. It's called the National Lung Screening Trial. And this was published back in 2011 in the New England Journal, showing that low-dose CT screening saves lives. And it was a fantastic study, but the criteria of the study was strict. It was, you have to be over 55, you have to have greater than 30 pack years smoking history, and you have to have stopped smoking within the past 15 years or quit smoke or currently be smoking. So what the USPSTF, so this is the body that provides the screening recommendations that most insurance companies and CMS listens to, they took the criteria from the randomized trial and applied it to the screening criteria for everybody. And then they slightly modified it back in 2021. But it's a complex criteria. And studies have shown, including studies by our team, but many others, that, for example, when you have a 20 pack year smoking history criteria, it excludes a lot of people who are at high risk of developing lung cancer. And really what you could do is simplify it. And instead of asking people how many pack years you have smoked, just ask them how many years have you smoked. And if you have a 20-year duration cutoff, you end up getting many more people who are at high risk of developing lung cancer, more the eligibility that they need to get screened. And also, I think from a health systems perspective, it's way easier to ask people how many years have you smoked as opposed to try to calculate how many pack years. The more I've done it and the more I talk to doctors and other healthcare providers who are working on these things and talking to patients, trying to calculate a pack year history is very complex because people don't just say to you, I have a 35-year pack year smoking history. They say to you, well, I started smoking a little bit when I was in high school. Maybe I quit a few years, and then I had a stressful situation happen in my life. And so then I started smoking 2 packs a day, and then I cut down for 5 years, and then I got back into it. And then to imagine asking a healthcare provider to figure out pack years with that level of detail in a short amount of time, on top of all the other things they have to work on for the patient's health, that's a lot. So I think that trying to reduce the complexity of the screening criteria can certainly help. And then there are many other things that we can talk about later in this podcast too.
Yeah, you are absolutely right. I've been doing some work with primary care providers, doing this myself in my own pulmonary clinic. And the one nice thing about eliciting a smoking history that way is that you really learn the person's whole life history, right? You learn about their jobs and their ups and downs and what happened in their family, their divorce, and when people died and everything. But yeah, there it is, probably 8 minutes later, and you're like, okay, what number did I come up with? So I think you're absolutely right. Trying to come up with that number is a huge barrier, a huge obstacle to figuring out who's eligible. Is there anything in the works that you are aware of that would sort of allow us to do that? I mean, I'm not aware that anybody's working on changing eligibility criteria. What do we need to do you think, to either get the criteria changed or figure out kind of a shortcut for people in primary care so that they can help us identify these patients?
That's a great question. So right now, the 20-year duration criteria, instead of asking somebody how many pack years you've smoked, but ask them how many years have you smoked, that we first published that in Journal of Clinical Oncology last year. And then 2 other groups have found similar findings in other cohorts. So the initial study that we did looked at the Southern Community cohort, which is a large-scale epidemiologic cohort, and the Black Women's Health Study, which is another large-scale epidemiologic cohort. And then there had been 2 other studies, one by Matthew Smeltzer and colleagues that was published in JAMA Network Open. It was also presented at ASCO, and another group out at Stanford has presented their findings at World Conference on Lung Cancer. And they all find that using duration as a cutoff is more equitable and allows for more people who are at high risk to be screened. And on the strength of these findings, the National Comprehensive Cancer Network, so the NCCN guidelines have now changed. So they have now said if you're over 50 years old and you either have smoked greater than 20 years or have a 20-year pack year smoking history, you should be eligible to get screened. And that is the official recommendation. They provide important recommendations that people listen to. The other really important organization that comes out with screening guidelines, they are also trying to simplify the recommendations. So American Cancer Society, they came out with their screening recommendations where they say you have to be smoking right now or have quit within the past 15 years. They got rid of that as well. So their recommendation is if you're over 50, if you have greater than 20 pack years smoking history, then you're eligible. So the USPSTF, they don't meet that frequently, and I am cautiously optimistic that if they are able to meet in the future, they're going to take a look at all these things. And probably when the next guidelines come out from the USPSTF, that will be in 2027. And I hope that at that time, it's going to be simpler. The criteria will be simpler from the USPSTF.
Right, because you're bringing up an important point, which is that different societies can make different decisions and different recommendations. And so I think this is one of these things that leads to confusion amongst people in primary care and people in the general public about, well, okay, American Cancer Society recommends this, National Comprehensive Cancer Network represents this, or either of those things covered by insurance, which of course USPSTF, as you said, is what drives insurance coverage. But sometimes these other societies are kind of on the leading edge, right? They're sort of pushing the envelope to change and expand screening criteria and hopefully get USPSTF to adopt those. And thank you for that important work because you and the other investigators that you mentioned are contributing to the evidence base that USPSTF needs, right? I think more than just society guidelines, they're really looking for studies, hard evidence to show that there's a need and a rationale for changing those screening criteria. So I will be looking forward to 2027, and I hope you're right about that for sure.
Thank you for saying that. We're going to make sure to keep working on this from the research front to exactly like you say, provide the evidence that's needed for those policy makers to update their guidelines. One thing that's interesting is that I do a lot of outreach in the community, and I have And one of the things that we are doing is collaborating with folks from other specialties. And as I'm learning about, for example, the colorectal cancer screening guidelines, in that right now, people are familiar with the 45-year-old recommendation, basically for average risk folks to start getting a colonoscopy or getting colon cancer screening at the age of 45. That, as you know, didn't used to be 45. It used to be older, 50. And one of the earliest organizations that dropped the age criteria to 45, it was not the USPSTF, it was the American Cancer Society. So to your point about how sometimes you need different societies to push the field forward, I think that you have seen that for example, in colorectal cancer screening.
Yeah, I'm looking forward to getting into a little bit more talk about your outreach and advocacy. If you're enjoying this episode of the Oncology Insights Podcast presented by WiseNetics, please remember to like, subscribe, and share it with your network. You can also set your notifications on from our channel so you don't miss any upcoming episodes. And please feel free to leave us a comment. Your feedback is always valuable. I had a similar experience myself in the lung cancer screening space I came to this caring about lung cancer, but before long, I realized I have to care about other cancers too, right? Not only can we learn from them, I mean, basically colon cancer screening and breast cancer screening are our older cousins, our uncles that we need to look up to and try to follow them and emulate them and learn from their lessons. But also when we are out into spaces, especially community spaces where we're talking about lung cancer screening, we want to make sure that people understand and have access to all of the cancer screenings that are helpful to them, right? Lung cancer is a serious disease and kills many people, but there are other cancers that need to be evaluated and also would benefit from early detection. So let's talk a little bit more about your community outreach. How are you commemorating Lung Cancer Awareness Month this year?
Right now, what we're doing is going out there in the community and teaching people about lung cancer screening all across the country. So I started this nonprofit called the American Lung Cancer Screening Initiative about 8 years ago. And right now, originally we started small, and now we have 133 college chapters where students from all across the country are going out there and teaching people about lung cancer screening. I'm here in Boston, and so I've been trying just year round to go and teach people about lung cancer screening. But in the month of November, we had some special events as well. And one of the things we did was go out there onto the Boston Commons, which is the beautiful park in Boston, and it's right next to the state capitol. And we planted 2,500 white flags. And that each flag represents a person who died of lung cancer the past year. And so that was an exhibit there in collaboration with Longevity, which is another nonprofit that does great work. And we wanted to recognize the patients and their families who had to have experienced lung cancer in the past year. But there are many other things that we have tried to participate in. So one of the things is we went on a walk. Our team went on a walk with Longevity as well. And we were out there going to different places like food pantries, to community health centers, I was even at a fashion show actually, where we tried to raise awareness about lung cancer screening. And then on National Lung Cancer Screening Day, which happened, I think, on November 5th, all of our chapters tried to do something special, whether or not it was collaborating with a lung cancer screening center or going on their own walk where they had different community members and patients come, or simply just tabling out there in front of the DMV to raise awareness about lung cancer screening. All of our chapters try to do something.
I have had the joy of being the faculty advisor for our brand new chapter at the University of Minnesota this year. I learned about the American Lung Cancer Screening Initiative about a year ago. And I remember seeing a map that you showed of all the chapters that you had and where there were not chapters. And I saw there's no chapter in Minnesota. I am going to do this. So I have some really inspiring and energetic young folks at the University of Minnesota who are working with me. And it's really cool. How did you come up with this idea? I think it's a really brilliant way to bring young people into it and to kind of harness their energy and their enthusiasm. What gave you this idea? How'd you come up with this?
Well, first, I really appreciate all of your time and mentorship of our students. They really appreciate it. And with regard to this, it kind of just came unplanned, I would say. So I was a chief resident in general surgery, and we had this thought of, let's try to raise awareness about lung cancer screening because I could see that folks were not getting screened. And initially the idea was, I went to residency at Duke, which is maybe 3 hours away from Western North Carolina. But the thought was that there was going to be a lot of people in Western North Carolina that smoked a lot or previously smoked, and we need to go out there and try to get folks screened. And I thought maybe at the end of residency, I would just basically have to pass it off to somebody because I would have no time during fellowship to work on this. But pleasantly, I realized that I could still squeeze in some outreach during my days off. And I was really fortunate to meet some wonderful students, such as Alex Potter from Berkeley at the time. And through that, and we just continued to collaborate and try to get more people excited. And so we started at Duke, then went to Stanford, and then, what happened was that the pandemic happened, and we started doing a lot of outreach virtually. And that was the period of time when I realized that you actually could, first of all, through Zoom, start talking to a lot of different students and also a lot of folks who are at risk of developing lung cancer just through these virtual sessions. And then once the pandemic started to recede a little bit more, we went back to in-person, but through all the virtual outreach, we already had established some connection. So for example, I remember one time we went to, originally we were going to go to a Native American powwow, actually in May of 2020. And that got turned into a Facebook Live event where 500 people ended up learning about lung cancer screening that way. And we realized that the power of this interconnectedness that could come from these virtual settings that then translated to in-person outreach later on.
Yeah, Facebook Live. I like that. That's a good idea because, I'm sure you have started thinking in a way that you didn't expect to when you undertook surgery training, right? Like you're trying to think like a marketer. You're trying to think like some sort of a person who is like, okay, where are the people who I need to reach? How can I reach them and meet them where they are and give them the information that they need? So Facebook Live is great. I haven't thought of that one, but I think just in terms of kind of what you're thinking about the demographics of people that you're looking for, older people. So I think that's great. And, the other advantage of the American Lung Cancer Screening Initiative, I'm sure you recognize and the students recognize that it's a wonderful networking opportunity for them. It's a wonderful leadership opportunity for them. So it's a win-win. I think they get to work with healthcare professionals. They get practice talking to people, right? A lot of college and medical students now, because of the pandemic and because of sort of social changes, don't have a lot of practice just talking to people. And that is really what it takes to become a doctor or any kind of a healthcare professional or a health advocate. So I think it's so cool. And it's really a wonderful opportunity for them and for everybody involved.
Thank you for saying that. You're absolutely right. One of the joys of working with students, and I think what the students get a lot out of, is learning how to talk with the community and learning about the issues that affect potentially their future patients, because many of these students want to become doctors, and they end up learning not just the barriers to lung cancer screening, but also the barriers to healthcare for many of these community members. I remember one of our students, for example, talking to somebody about lung cancer screening, and really one of the participants, they said, the community member that they were talking to told her that, okay, that's great, but I really have to first take care of the rat situation in my apartment. And then once I get that done, then I got to figure out how to get health insurance to go see a doctor. And then I will work on this. And so then that student was very kind and actually helped navigate this community member through all those different steps, and then got that person screened a year and a half later. And so these experiences are, I'm sure, will help that person be a better doctor and also a better leader of the community in the future.
Yeah, I totally agree. They're seeing the kind of hierarchy of needs, in real time, right? Not instead of learning about it in a book, but yes, rats take priority probably. Well, virtual high five to you for that endeavor. It's really been a joy. So what other kind of approaches have you been taking to increase lung cancer screening uptake? Is there anything that you're working on that we haven't talked about yet? We've already talked about so much that you've been doing.
Well, thanks for asking that. There is, other than eligibility criteria, there's actually a lot of major issues that the health systems can work on immediately. And one of them is going out there into the community. So in that regard, my team and I, we do work with our Mass General Brigham community care vans, where these community care vans, they go to different places to the people, so that for people who are busy and might not have time to travel to an actual clinic or the hospital, we're there already. And so I'm excited about that work that's been going on for 2 years now. And the other thing I think is really important is advocacy. And so I've been trying to work on, with our team, supporting bills that would allow for better lung cancer screening access. So for example, there is a bill out there where, if passed, it would allow for more funding for mobile CT lung screening trucks. So essentially, the idea would be right now, and actually there are different places, for example, in Roswell Park, led by Mary Reed, or down in Tennessee by Rob Hedrick, where these centers already have a really big truck, and the truck has a CT scan in there, and it just drives to different places. For example, to the supermarket parking lot, and then people can get screened there and make screening easier. And so this bill, which had been introduced, if it gets passed, then it would fund more of these nationally, or help fund more of these nationally. And another avenue of advocacy that our team has worked on for the past 5 years now is we have worked with senators to help them create and pass resolutions that recognize Lung Cancer Awareness Month and the importance of the early detection for lung cancer. And so this was something spearheaded by Alex Potter back when she was a college student. She's now a Harvard medical student. But basically, at that time, working with Senator Tina Smith and Senator Marco Rubio's offices to write up a resolution that was then introduced and passed by and agreed upon by all 100 senators on the importance of lung cancer awareness and early detection of lung cancer. And so every year we've been working with the Senate for 4 straight years, and we're going to hopefully be able to have another one passed as well this year. And then working with mayors and governors. So mayors and governor offices often have proclamations where they try to highlight something important. And so we have worked with them to highlight lung cancer screening and lung cancer awareness. And in that regard, we have worked now with 680 mayors and governors where they've issued these proclamations. And what we've found from these experiences is that a lot of public leaders actually have personal experiences with lung cancer. So, for example, Mayor Jane Castor from Tampa, she had 2 relatives who had lung cancer. And when we talked to her, she was really excited and passionate about helping us, and actually invited one of our students, Maya Sharma, to go speak at the U.S. Conference of Mayors, where she taught 50 other mayors about the importance of lung cancer screening. So we're trying to approach this outreach from many different sides, from just going out there in the community and talking to people. And sometimes that is just going out there in the library, for example, and talking to 5 people, to trying to do something much bigger where you can have events planned and reach 500 or 1,000 people, to legislation and advocacy.
Yeah, sometimes, you put a lot of work into an event, and we've been in situations where we don't really talk to that many people. Everyone we talk to is like, no, I don't know anyone who ever smoked, and you're kind of like packing up. And then like one person comes at the end and they talk to you and they're eligible and they're excited about it. And you give them information, help, and you're like, okay, this day was worth it. We reached one person who we think might be able to have an important impact. Okay, Dr. Yang, I wonder now if you can tell us a little bit about a study that's been getting a lot of attention out of Taiwan, the Taiwan Lung Cancer Screening and Never Smoker Trial, or the TALENT trial. Can you tell us a little bit about that?
Yes, this is a very important trial, and in lung cancer screening for people who have never smoked, I think is a very important consideration and area of future investigation. And that's because there are many people, especially in Asia, with lung cancer who have never smoked. And in fact, the overwhelming majority of Asian women with lung cancer have never smoked. And in the US, about 77% of Asian American women also have never smoked. So, and clearly none of those people would be ever eligible to get screened based off of the current criteria, because based off of the current criteria, you have to have had a smoking history. And in that trial, anybody who was between ages of 55 to 75 years and either had never smoked or smoked fewer than 10 pack years, and had one of the following risk factors. So, for example, family history of lung cancer, a history of COPD or TB, or what they call the cooking index of 110 or higher, or cooking without ventilation, they would be eligible to get screened. And the study found that the lung cancer detection rate was about 2.1%. So they were finding lung cancers. Just to give you a comparison, in the National Lung Screening Trial, this is the U.S. large-scale randomized trial, the lung cancer detection rate for a first-time scan was about 1%. So this trial shows that lung cancer screening is important for people who have never smoked. And so in Taiwan, they now have a national lung screening program that allows for, one of their eligibility criteria is now does allow for people who have never smoked.
I'm sure many advocates for lung cancer in the United States would love to see that here, right? I hate to leave any conversation about lung cancer without, saying the simple fact that anybody with lungs can get lung cancer, right? And so the TALENT study really kind of highlighted that other risk factors are really important, and maybe a light or no smoking history are still, along with another risk factor, is something that still warrants screening. What do you think it's going to take in the United States? What's the future of screening for people who never smoke cigarettes?
That's a great question. So right now in the United States, about 15 to 20% of people with lung cancer have never smoked. And by different estimates, that if you just looked at never smoking lung cancer, that is the 5th to the 7th leading cause of cancer death in the US. So it is a profound problem and very, very, very critical public health problem to try to figure out, how do we get folks who have never smoked the appropriate screening. I think in the US with lung cancer screening, the policymakers have always grappled with the the risks and the benefits of lung cancer screening. And I feel that more and more people these days have recognized the benefits of lung cancer screening and and are starting to realize that the risks of lung cancer screening are actually very low. So, and that's because of improvements in either technology or the way we read CT scans or how we take care of patients with lung cancer. So one thing I wanted to highlight is that, for example, when the National Lung Screening Trial came out, and when they talked about the different false positive, the pretty high false positive rates and all that, that's a thing of the past. So the radiology field has since adopted more specific and better criteria so that not every single nodule, or I should say, so that many more nodules that previously would have been called as a positive are now just appropriately triaged and just followed up with instead of getting further workup for. So that's one area. And then on the downstream end of lung cancer screening, that's surgery. And surgery has vastly improved since 2011. So back when the trial was published in 2011, 70% of the operations that came from lung cancer screening were actually thoracotomies. So these were large incisions from the front all the way to the back. You have to have a controlled break of the rib. You have to spread the rib in order to gain access to the chest. They're big, they're painful operations and often associated with patients staying in the hospital for a week. Nowadays, over 80% of operations for stage 1 lung cancer in the US is done minimally invasively. And for screen detected lung cancer, the rate is even higher. And so that means that patients often go to the hospital and sometimes you get your operation and you leave in one day. So the downstream effects of lung cancer screening, surgery or SBRT is another treatment that you would do for patients with lung cancer, early stage lung cancer. That is really safe as well. So I think that, Abby, I know this is a long-winded way of answering your original question, which is what is it going to take? I think that part of it is you have to have a recognition by doctors and people in the field that lung cancer screening is really better than it has ever been. With a lot less risk and a lot fewer side effects than in the past. Or even in 2011 with the NLST trial, the benefits far outweighed the risks, but now it's even better. And the reason why I mention that is because I think that people are really worried about overdiagnosis, overtreatment, and the harms that could come from lung cancer screening. And so they don't want to subject people who are otherwise really healthy, who have never smoked, to those kind of risks. And so understanding that lung cancer screening is safer than ever and treatments are better than ever, that's the first step. But the second step, to answer your question, that I think personally needs to happen is I think there needs to be a randomized trial. Me personally, I already see the benefit in lung cancer screening for people who have never smoked if you do it thoughtfully. But I just have a feeling that the USPSTF will never, ever approve lung cancer screening for people who have never smoked unless they see randomized controlled data. And so in that regard, I really hope that our field just tries. It's going to be very hard to do a randomized trial for people who have never smoked because it's just always hard to do a study of that magnitude. For example, the National Lung Screening Trial cost about $300 million and took several years. But I think that we need to figure out how to do that trial in order to get the guidelines changed.
Yeah, I agree. Well, that's okay. You took us on a journey, but I think you brought up some really important points about how the treatments for lung cancer have changed so much. And as you mentioned, the way that we interpret screening CTs, right? So the threshold that we use for what's considered an abnormal exam and how we can safely and more judiciously manage biopsy, remove, concerning nodules. All of those things have made screening definitely safer since even that trial was published. Well, I think on that we can probably wrap up unless there's anything else you want to tell us about. Is anything coming soon that we need to be on the lookout from your team and your lab?
Thanks for saying that. Well, I think one highlight, because I know I gave a very long-winded answer, is just to give you a sense of how safe, for example, surgery is now. At most centers, the 30-day and 90-day mortality for surgery for screen-detected lung cancer, it's 0%. That means that if patients go and get surgery, they're going to live and they're going to do well. And back in the day with the National Lung Screening Trial, the 30-day mortality was 1.3% for surgery for stage 1 lung cancer. 1.3% is very low, and it suggests that surgery is safe even back then, but now it's even safer. To be able to tell people, look, these are several centers' experiences, they're all published, they're all at 0%. It should hopefully provide a lot of reassurance and also show people it's just something easy to remember. 0% 30-day mortality, 0% 90-day mortality, and just a reflection of how much better the downstream effects of lung cancer screening are compared to 13 years ago.
Well, thank you very much for your time today, Dr. Yang. It's been a pleasure.
Thank you so much. We really appreciate the opportunity to be here and to share more about lung cancer screening with your audience. Thank you.
That concludes another episode of the Oncology Insights Podcast presented by WiseNetics. Thank you for joining us today. Don't forget to subscribe to our podcast to stay updated for future episodes. And if you enjoyed it, please leave us a review and share with your network. Until next time, this is Dr. Abby B. from the Oncology Insights Podcast signing off.